Thank you very much. And on behalf of the National Cancer Institute, I wish to welcome everyone to the February Advanced Topics in Implementation Science webinar. Today we are delighted to be joined fireside by Dr. Karen Emmons and Dr. Larry Green. They, of course, will be joined by our own Dr. David Chambers to moderate the session. A very brief word about logistics, and we'll be off. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded, and muting all lines will help us to avoid any background noise. We encourage questions. They can be submitted by using the Q&A feature on the right-hand side of your screen. Type your question in the provided field and hit submit. Feel free to submit your questions at any time, but we will be opening the session for questions when the presentation is finished. With that, it's my pleasure to turn it over to Dr. David Chambers.
Thanks, Sarah. As you can now see with the relatively limited slides, this is a chance for us to talk with two wonderful people and leaders in our field, Karen Emmons, as you can see, Dean for Academic Affairs at Harvard's T.H. Chan School of Public Health, and Larry Green, Professor Emeritus at UCSF, Department of Epidemiology and Biostatistics. For those of you who have joined us over the last few months as we've tried out this new format, you'll recognize that this fireside chat is a chance to move beyond the PowerPoint slides and really to get a sense from leaders in our field over recent and over many years, what drives their thinking about where the field should go. It is intended to be with as much room for as many of you around the fire as possible, and so with that, we're really encouraging of anyone at any point to ask questions. You'll see in hopefully the Q&A box is a place where you can type it. We'll kick things off with some sort of overarching questions and discussion. But again, this is a chance really to learn from two people who have a wonderful breadth of expertise and experience to share with us. And really just thinking about where have we come as a field, what are some of the key challenges, and where are we going in the future. For this particular month, we really wanted to emphasize, because it's not always as clear or as apparent, the important connections between implementation science and public health. Often, a lot of our implementation science is thought of within clinical contexts or some local community settings, but we have so much to benefit from in really thinking about how our science can contribute to the overall health of the population, of the public, and to what degree public health interventions can be adopted, implemented, and sustained to have as broad impact on our health and our health care as possible. And so the emphasis this month is really to learn from leaders in public health and implementation science just about what they're thinking, to ask questions, to just have a good chance of seeing what they're thinking and what are the needs that we should be focusing on as we attempt to continue to build the field. Just a couple of notes. Karen Emmons, I've known for a number of years. I think one of the amazing things that Karen embodies is both incredible sort of friendliness, incredible wisdom, incredible expertise and experience. And so as I was working in NIMH and starting to get to know what implementation science looked like beyond just the mental health setting, it was really Karen who was one of the key people who made me actually want to think more about cancer control and population science, more about public health. And it's probably a pretty direct reason why I found such a nice home here in the National Cancer Institute over the last couple of years. Larry, I think, represents for many of us a real leader in public health over many years. To me, he also represents someone who plays a mean ukulele, but who has rarely brought that ukulele to meetings that I've been at. And so my hope is, even though today at the fireside chat we will probably not be hearing from his ukulele, that in the future we not only get his expertise, his experience, his thoughts about public health, but we get some wonderful strumming of the ukulele down the road. So with that as a backdrop, you're probably thinking, what an interesting fireside chat. Wanted to jump in and maybe start with Larry. With your thoughts, going back a ways, what inspired you as you were focusing on public health? What inspired you to think about implementation science as a way to move public health forward?
Well, thanks, David, and thanks for the honor of this invitation to join you and Karen. I think I can relate to developments during 3 stages of my career, early, mid, and late career. And my early interest arose from work in Bangladesh, where a team of us from UC Berkeley, with Population Council support, tried to disseminate and implement strategies we were testing in controlled urban trials in Dhaka. It was then East Pakistan, now Bangladesh. We soon recognized, though, that as diffusion theory would have us understand, that every village we tried to take these tested interventions to required adaptations to their local subculture, setting, and circumstances. In mid-career, I served on the initial U.S. Preventive Services Task Force doing systematic reviews of medical interventions, but as a public health professional, I doubted the generalizability and applicability of many of the recommended interventions to public health settings. In late career, as director of the Office on Smoking and Health, then as director of CDC's Office of Science and Extramural Research, I tried to promote research that would apply CBPR, community-based participatory research, and evaluation research to produce more practice-based evidence in community or population settings. And it's there that I think I remain stuck as I try to see more expansion of controlled trial data, evidence-based practices, and clearly, in my mind, the need for more practice-based evidence.
Great, thanks, Larry. Karen, can you just respond, give us a sense of what inspired you to move more into implementation science?
Yeah, absolutely, and thanks so much for the opportunity to be here today and to share this fireside with both yourself and with Larry. I really appreciate it. So, you know, there were really two things for me that got me focusing on implementation science. And the first was really personal. It was really my mother's experience with healthcare. And, you know, she lives in the Midwest. And time again, as she was going to her doctor's appointments, I would talk to her after her appointments and find out that she'd basically not been getting any guidelines or evidence-based cancer care or cancer screening. And so, you know, really bothered me that I was working in this area of cancer prevention and my own mother was not benefiting from the science that we were developing. So I started, you know, developing this elaborate system to note her doctor's appointments in my calendar and then calling her in advance and sending her information and giving her talking points and doing role playing with her about how to ask her doctor for these things, and created this whole sort of infrastructure around her to try and help her get the care that I thought she deserved. And it did largely achieve the goal for her, but it didn't impact on the care for all the other moms and dads and, you know, all the people who we care about being cared for by her provider or in other locations. And of course, as soon as I stopped doing that, then the whole kind of system fell apart. So I had this really personal feeling that my mother and all of our parents deserve much better care. Then in terms of my career work, I had conducted several intervention studies that had really demonstrated that our interventions were successful at reducing cancer risk factors. And I've been working mostly in disparities and largely with vulnerable populations. In particular, I had two areas where we had really good outcomes. One was in reducing secondhand smoke exposure among young children in low-income families. And in that work, we were in homes, and we did a lot of home-based interventions. And it was, you know, we're becoming part of this, the infrastructure of these people's lives and part of their community and getting to know these children. And then in the second set of work, we were working on smoking among child cancer survivors, which was CBPR work, as Laura mentioned. And it became such a personal issue for me that, you know, we have these important findings, and they're not really being put to use for these communities that really needed and deserved access to these kinds of interventions. So for me, it was sort of the disappointment of, you know, discovering that this great work that we were doing was really not leading to any improvements in anybody's health. Was probably my naivete that would just happen that way. But that was really what pushed me into this area.
Great, thanks very much. And Karen, starting with you, I wonder if you might reflect on, so as you decided that this was an area of emphasis, what was the state of the science of implementation like when you started work here? What did you find? And as you said, here are some of the reasons why I'm motivated to try and do a better job of ensuring that these interventions get to those who can benefit from it.
So, wow, I'm going to really sound like an old-timer now, but when I started in this area, it was, I think, D&I work was, as I say, a twinkle in the eye of, Barbara Reimer and Bob Croyle and John Kerner and the folks at NCI that really got attention to this area. When we were finishing up our first childhood cancer survivor study was right at the time that the first supplement from NCI to focus on dissemination implementation science was released, and that was just like the perfect timing for us. And it also was right at the time that NCI was doing a lot of focus around designing for dissemination. So we really had not talked very much about how we needed to create interventions that could have impact but also be scaled. As a field, we had been so focused on efficacy and basically pretty much ignored the rest of it. So we had these really complex and expensive interventions that were very difficult for most healthcare settings to adopt. And I think the other thing that was going on at the time that I started in this area was that we had a super limited set of evaluation methods that were considered to be fundable. It was pretty much the RCT, and this really intensive focus on internal validity. And that was really at the time when several of our field leaders, including Larry, as he, I think, just alluded to, really started to take the field to task about improving the focus on external validity. This was so important because prior to that, you pretty much couldn't get studies funded if you didn't use, the RCT and my air quotes of rigorous methods. But now we have a really large toolkit of rigorous methods very, very happily. So we just didn't have the theories, we didn't have the tools, we didn't have the sort of funding support in the very beginning, but over time that has really, really shifted.
Great. And Larry, I wonder if you could also reflect on, so what did implementation science look like, and particularly thinking about public health, when you started working in the area?
Well, if Karen feels like an old-timer, I'm a grand old-timer because implementation science wasn't even a term with any broad use at NIH support. When I did my early research at Hopkins, footnote, Barbara Reimer was one of my doctoral students at Hopkins. The names that were closest to what we now call implementation science were people like William Foote White, who studied street-level bureaucrats as the point at which policies were not getting implemented down to the community level. Anselm Strauss on negotiation, Lee Cronbach and Campbell and Stanley, who introduced the term external validity and showed us how it gets compromised in experimental and quasi-experimental designs. The real wake-up call, though, I think for me, was the NIH commit trial. When they tried to take the Stanford, Minnesota, and Pawtucket community trials to scale with a broad North American test in various communities, but they didn't allow the communities any real say in how the interventions were to be implemented. They had to be implemented, quote, with fidelity, with all of its moral overtones. And so in muzzling the community's voice in implementing these interventions, as well as they may have worked in the Stanford, Minnesota, and Pawtucket trials, they weren't working in most of the communities in the commit trial. Then in the early 80s, my wife, Judith Otteson, in her doctoral dissertation at Harvard, studied implementation in the early 80s, and we published together my first article on reconciling concept and context, a theory of implementation. So that's sort of the trail that leads me to the positions I described in the previous question of interest at various stages of my career.
So I'm going to take a moment just to Sarah again with NCI just to jump in and say we are expecting quite a few folks, and so if you are on the line and you are muted, thank you very much. If you are not muted or unsure, please check your phone or your computer settings to mute any background noise that might occur during the meeting. We'd really appreciate it. And again, questions can be submitted anytime using the Q&A feature, and I will step back with that and we can jump into the next question.
Great. Thanks, Sarah. So, Larry, starting with you, if you might give some reflections on, as you've seen the field move, grow, change over the field over the years, what would you say are the major changes that you think have been, hopefully beneficial to the expansion of the quality and quantity of work in the area?
Well, as I implied in my previous response, the early concern before NIH interest in implementation was with policy implementation. And this was in the 1960s when Presidents Kennedy and Johnson pushed an awful lot of legislation that called on states and localities to implement federal policies. And they ran into real roadblocks in the South, but elsewhere as well. And implementation science really became a question of how do we get policies more effectively implemented. In the middle years, as we focused on systematic reviews of scientific evidence, we began to question how well are we getting these interventions that systematic reviews would suggest ought to apply everywhere. How do we get them implemented in specific settings? And that really began to question the external validity, the generalizability, the applicability of interventions that are tested only in the best randomized trials. And then finally, I think the recent pushes around community-based participatory research and other means of getting user involvement in generating evidence and adapting RCT evidence to local situations have created a third generation of interest in other types of evidence, practice-based evidence, that may not be as rigorously controlled, but that shed a lot more light on what needs to be done locally.
Great, thanks. Karen, thoughts about how you've seen the field change over the years?
Yeah, I would agree with everything that Larry said. I think that one of the things for me is the range, as I mentioned earlier, the range of methods and designs that we now have developed and really have the ability to use for different kinds of questions. It felt like in the past we had one primary method that was accepted and we would use that hammer for everything, whether it applied or not. And now I think we have a lot more sophistication, a lot more range of methods that are acceptable to help us get much more nuanced in the kinds of work that we do. So between mixed methods and smart designs and just a whole range of ways to approach implementation science questions, I think we're much better positioned. I also think there's a much less willingness now to ignore these issues of external validity and scalability, and that's really good news for those of us who care about implementation. That's not so good news for people who just want to develop interventions and not think about the applicability and the long-term, implications for broader use. But I think that is just really, really important driver of the field. We also have a lot better conceptual frameworks. When I first started in this area, we had diffusion of innovations and Roger's work, but there weren't a lot of other theoretical frameworks in our field that really to draw on. And so people, I think, were looking in a lot of different areas, some in business and other areas, agriculture, but not so much in, certainly in public health. So I think we're in a very different place now. And if anything, we have so many conceptual frameworks, it's now maybe the opposite problem, trying to figure out what makes sense, what are the overlaps, and so on. And then I guess the last thing I would say that's changed for me is we have an increased focus on the science of implementation science and really trying to figure out why implementation works or doesn't, rather than just trying to get things implemented. So it's that, really looking under the hood and saying, look, the outcomes of this, whether it's picked up or not, as long as we understand it and then can utilize that information, that is a really important goal. Of course, we want implementation to work, but it's that deeper level of understanding, which I think in the past we haven't been so open to.
Great. So sort of mechanistically really trying to understand how and why things work, or when they don't, how and why they don't, right?
Exactly, exactly.
Cool. So for each of you, would love, you've done a really nice job over the last 20 minutes or so, giving us a sense of how far we've come. I'd love to get each of your thoughts. Karen, we can start with you and think about where do we go from here. So what each of you sees as key next steps for implementation science, and again, particularly thinking about the area of public health.
Yeah, so I love this question. And I have to say that Graham Polis and I have been doing a lot of thinking about this in some of our writing together. So I'm going to kind of, in my answers, steal from our collective thoughts on this. One of the areas where I really think we have to focus on is reducing the variability in evidence implementation by setting, by location, by state. And let me back up a little bit and tell you why I think that's important. I work in cancer prevention, and I think that implementation science has a really important role to play in reducing cancer morbidity and mortality. And if we just uniformly applied what we know, so if we made what we know, what we did in cancer prevention, we could prevent more than half of the cancers today. And we have this really robust set of tools. We have, if you think about tobacco, inactivity, obesity is all modifiable causes of cancer. We have interventions for most of those that have at least some level of efficacy and effectiveness. Vaccinations, use of aspirins, CBRNs, and there's screening. There are so many tools that we have in our cancer risk reduction toolkit. And really, when you think about the impact of these strategies on cancer outcomes, they way outpace anything that's, in the development that I'm aware of in the biologic or genetic realm, where we seem to put so much emphasis. As a research enterprise, we so worry about those areas, and we don't pay as much attention to the tools that we have in hand. But when you think about it, there's huge potential of taking what we know and implementing it. And what's incredibly important, I think, is understanding why we've had such inconsistency in our implementation of evidence. So let me give you an example of tobacco and tobacco taxes. There's really strong evidence that increased taxes lead to decreased tobacco consumption. And raising tobacco taxes is actually a very key cancer prevention strategy. But when you look at the states, the 50 states, that state excise taxes for tobacco range from 17 cents to $4.35 per pack of cigarettes. And 1/3 of U.S. states have not raised their taxes in 10 years, which I think is astonishing when you think about the revenue sources that could come to cash-strapped states in these taxes. Now, I'm sure most of you are thinking, well, of course, Karen, that's obvious. It's the southern and tobacco-growing states that have the lowest taxes and are least likely going to raise them. But that's not quite the story. The lowest tobacco rate, tax rate is actually in Missouri at 17 cents, not in North Carolina, not in Virginia, but Missouri. And if you look right in the middle of the country, Indiana and Iowa have relatively low tobacco taxes and have not increased them in 10 years. But in between is Illinois, that has much higher taxes and has incrementally increased them. So what do we learn from those variations? What can we learn that will help us really understand, for example, how states are going to respond to what we anticipate will be changes in the Affordable Care Act that are going to reduce access to evidence-based tobacco control treatment and other kinds of cancer prevention treatments? And how do we use that knowledge going forward? I think we have a lot to learn in understanding variability.
Thanks, Karen. Larry, same question for you. What do you see as key next steps for implementation science for public health?
Well, I think I can't disagree with anything that Karen said. I would summarize much of it with the phrase that'll probably be on my tombstone: if we want more evidence-based practice, we need more practice-based evidence. And I think program evaluation, CBPR, quality assurance, improvement strategies, all of these, I think, represent the kind of practice-based evidence that we need to systematize more as complements to the evidence-based practice we're getting from the systematic reviews. I think better adaptation, nuancing, and qualification of the recommendations from systematic reviews, U.S. Preventive Services Task Force, the Task Force on Community Preventive Services, the Cochrane collaboration. I think we can ask them to account for the limitations of external validity in the original trials. There's an article just out in the March issue of the American Journal of Public Health from our CDC colleagues on the Community Preventive Services Task Force that addresses some of this. And I think they make the point that, in fact, there is considerable external validity, both in the evidence-based practices and the practice-based evidence that gets woven into their recommendations. So I'm pleased to see that they've responded to that challenge. Finally, I guess I would urge or consider greater recognition that not only are outcome data from RCTs limited in their applicability to varied cultures and circumstances, but so too are the theories that produce the experimental interventions. I think we somehow convinced ourselves that theories apply universally, but in fact they were generated frequently or most frequently in Anglo-American research. And those theories might have taken a different form if they had been generated in Latin America or Asia.
Great.
Pause.
Yes, no, that's really helpful. I was noting actually, and again, encouragement to those who are listening as you have questions to keep them coming. I noticed one of the questions that we've received already, which is along a similar line as the previous one that each of you answered, and that's again, thinking about the future of implementation science. What do you believe the field needs, say, over the next few years to answer existent and anticipated gaps in the literature? I know sometimes we think about different partnerships that might be needed, and so it'd be great to have your sense of that, but just other ways in which you think we need to build more capacity to make sure that we're answering the key gaps that science has told us exist. And Karen, do you want to give your thoughts on that?
Sure. Well, I think I've already sort of tipped my hand that I think trying to understand and reduce variability in implementation, I don't mean the process of implementation, I mean putting our evidence into practice. I think that's really critical, and I think Larry's right that a lot of that comes from understanding practice, developing more practice-based evidence, but I also think that there are a lot of other contextual factors in trying to understand what goes into influencing, for example, policy that is just incredibly important in implementation science. And Larry noted that in our past history, there was a lot of emphasis around policy implementation, and at least from what NIH is interested, it feels to me like we've kind of lost that focus, and I think that's incredibly important for us to start thinking about, because there are so many multi-level strategies that we don't really study in quite the same way that we do more individual level strategies in implementation. So I think that's quite important. And I guess the other area that I would focus on for priority areas for the future, I think we're starting to see more of this, but it's really the area of de-implementation. So it's implementation science to me is not only, doing what we know, but also not doing what we know is not helpful. And I think we haven't fully embraced that, particularly in terms of what it means to tell people that something you've told them for, 3 decades or 2 decades that they should do, suddenly they shouldn't do, and what are the implications for that, and how do you really bring that forward is really important.
Great. Larry, thoughts about what the field needs over the coming years to answer the key gaps in the literature?
Yeah, I'll give you my top 3 candidates. Multi-center collaborative trials, I think, with variations on the interventions to reflect variable cultures and the local concerns, demographic and socioeconomic composition of the populations. I think we've done multi-center trials with a view toward homogeneity of the communities rather than heterogeneity. Examination of social determinants of health not just for their correlation with health outcomes, which we've been flooded with in the literature in recent years, but for the mechanisms by which they influence health behaviors. And I think this case was made very well in an article last month in the American Journal of, well, in January, American Journal of Public Health by Maria Gleimar and Karen's colleague, Elena Spiegelman at Harvard. They've really made the case, I think, for looking at social determinants of health more at the mechanism or mediating variables level. And third, I think more attention to practice-based evidence within the studies selected for systematic reviews. And that case has been made, I think, in the article that Russ Glasgow and I did in 2006, and many others have since probed that question of external validity. Those are my candidates in response to this question.
Great, thanks. I wanted to actually, I noticed that we have a question that came in here that actually seems like a nice follow-up to this notion of practice-based research, practice-based evidence. I wonder, and we can start with Larry and then Karen, your comments. What do you see as the role of practice-based research networks or community-based research networks moving forward?
Well, this was a question that was addressed by an IOM committee in 1996 when the prevention research centers were funded by CDC with funding provided by legislation. And the IOM committee came to the conclusion after the first decade of those prevention research centers that they had kind of missed the ball that had been tossed to them on engagement of their communities. They used the funds primarily to pursue their own academic research and not to engage the communities that they were expected to be serving. So I think that's where the big partnership problem lies, is getting the academics more effectively engaged with their natural community agency partners. And then I think the other element that is probably our biggest gap in data available to do the kind of research we're talking about is the surveillance surveys that we have, the National Health Interview Survey and other surveys that reach down at least to the state level, but not to the community level because of the cost of sampling down to that level. But communities where we really want to see the rubber meet the road are really deprived of the kind of surveillance data that would enable them to do the evaluations of their programs, to produce more practice-based evidence. That's my take on this.
Great, thanks, Larry. Karen, thoughts about how you see the role of PBRNs or CBRNs moving forward?
Yeah, I mean, I think Larry's focus on CBPR and these kinds of partnerships in implementation science is exactly spot on. You know, really when you think about it, all implementation is largely local, right? You're taking something, you're adapting it to a local setting. And so I think having these kinds of partnerships that bring groups together is just incredibly important. And then taking that out in terms of networks, trying to figure out how to learn from a series of local implementations is a real missed opportunity if we don't do it. So I think that's critically important. I guess, you know, the other place where I feel like partnerships are needed is really in the with local and state policymakers. I think, especially now, we're unlikely to see federal legislation or policies that are necessarily going to be helpful at promoting implementation of some of this evidence. And so I'd like to think that much of this is going to happen, and I think we've seen this in tobacco, and we're seeing this in sugar-sweetened beverages and a whole variety of areas. It really is, the action is more at the local and perhaps state level. So how do we form partnerships in the policy and with our local health departments in that arena that can really help us move forward?
Great. One thought that, given that you're talking in a webinar that's run by one funding agency, if you have thoughts as to, are there ways in which I guess funding organizations interested in implementation science should be thinking about advancing the science further? Is there something that we should be thinking about in terms of incentivizing some of the partnerships that you've talked about, or just any other thoughts that you think, that as you've seen different efforts to try and stimulate more work in this field, are there things that would help from the funding agency that you haven't necessarily seen? And Larry, you want to kick us off with that?
Yeah, I think I have to start with the overworked metaphor of silos. The federal silos are one of the barriers to addressing problems the way communities perceive them, the way populations perceive the problems. So NIH partnering with CDC and SAMHSA and AHRQ and other practice-based federal agencies, I think, is one big step that has been taken and needs to be pursued more actively. A second, I think, is getting the academics working more, or requiring them, if they want a grant from the federal government, to work more with their community agency partners. And the third is, I think, getting these assuring program and service grant applications to document their partnerships and to require evaluations and development of evaluation capacity at the local level.
Great, thanks, Larry. Karen, thoughts on this question of opportunities or ways that funding organizations can advance the science further?
Yeah, I love it when you guys ask us to tell you how to spend the money, so thank you for that question. Just adding on to Larry's last suggestion, and that is around developing community-based evaluation capacity, and I think that's incredibly important, and I think actually it's also very important to include resources for that. So what often happens is, at least in my experience, that's kind of an add-on or a tail-on, and it often gets dropped because it's not properly budgeted. So I think that, not only requiring it, but also funding it is really important. I guess the other big area that I would say for funding organizations is to provide more flexibility around understanding the timing of implementation effects. I'm not always sure that our implementation work fits a 2 or 5 year cycle exactly as we think about it for more I guess for our medical work, wherever that, the timing of our research funding came from, I'm just not sure that that fits with some of our implementation science work. Certainly the cadence of trying to get things funded doesn't. I know there's a rapid cycle for policy funding mechanisms that could probably be way expanded and made even more flexible would be very helpful. But I do think thinking much more about the natural timing of implementation, what it takes to study that, and thinking about the funding mechanisms in that regard would be quite helpful.
Yeah, no, thanks for that. And recognizing, again, that sometimes you're trying to apply what are more general mechanisms to a dynamic, ever-changing field. So appreciate that. Couple of questions have come up from folks, which is great, bring them on, that concern, I think, stimulated by a few things that each of you have said, and particularly I'm thinking, Larry, when you were talking about how, to what degree the evidence base is as compatible with different populations, to what degree it might actually give an opportunity to focus on the interface between health disparities and implementation science. And so I'm going to give you a couple questions that summarize the space, and maybe Larry, get your take, and then Karen, yours. The first question is what you think about the potential to move the implementation science field forward by conducting efficacy trials in community settings, specifically to reduce health disparities across race and ethnicity, And then an additional question, thinking about health disparity research in the context of chronic disease management, how do you think about implementation science being integrated across these different fields? So if we recognize, and this is part from the question, if we recognize that there's increase and continued increase in the diagnosis of multiple chronic conditions across the population, and not necessarily as much robust empirical findings between the two fields, how do health disparities research and implementation science come together? What suggestions do you have for work in that field? Larry?
Well, I would worry if the emphasis was placed on efficacy trials to pursue this, because I think the biggest problem produced by efficacy trials, for all of their virtues and internal validity, is that in order to achieve the degree of internal validity that we ask of efficacy trials, we almost necessarily have to compromise on conditions of the experiment that limit external validity, the degree to which we control the intake and the selection of the subjects, the degree to which we limit any variation by the interveners on how they're intervening, and onward. The variety of things we do to achieve internal validity for purposes of efficacy trials, the greater the degree of sacrifice of external validity, not in every way that we intervene, but in many of them. And so we have a paradox there. There's another paradox, however, with community-based participatory research, and that is that the more relevant we make the research to a locality, the greater we may, in fact, have problems generalizing it to other settings. So I think we have a necessary trade-off that we have to acknowledge and ways and look for ways to complement the two types of research.
Great. No, thank you. Karen, your thoughts on this?
Yeah, that was just a superb answer, and I totally agree with what Larry has said. I don't actually see health disparities in implementation science as orthogonal in any way. I think that implementation science is a very important strategy to help us reduce health disparities. So I think that that's very important. I think to add on to what Larry was saying is part of when you're doing these kinds of local implementations and you're using CBPR and you are getting very, focused in the local context, I think it's really important to also understand some of the broader contextual factors facing that implementation. And so I think some of our models that we've developed or that have been developed around implementation science and the conceptual frameworks that allow you to look at some of the outer setting factors, those are really important as we think about health disparities, because it, I think, allows us to think about what are the prevailing conditions, what are the issues going on around this setting and this implementation that might help us understand how this would work in other places. So again, it's this sort of multi-level approach applied to implementation science I think is quite critical.
Great. Thank you both. So wonderful questions that are coming up. So thank you very much for those already in and more to come. Want to shift gears a little bit with another question that we got here that's asking, it's asking our invited guests to reflect on roles and intersections between implementation science, design thinking, and system science. That is, given the complexity of implementation in healthcare, what can we learn from designers, engineers, and other fields that will be helpful for implementation science? Karen, any initial thoughts on that one?
Oh, thanks for starting with me on that one. I appreciate that. That's a
You're
really
juicy,
meaty question.
I figured it was an easy one, right?
Yeah, thanks. Yeah, thanks for that. But it's a really critical one. And, we're starting to see, I think, these fields coming together more in large part. I think, NCI and others have been really thoughtful in trying to bring system science into some of the implementation science trainings that have been going on. So I think that's really quite excellent. And there have been people thinking about this for a long time. I think Doug Luke is someone who's been doing some really terrific work in this. Some of the engineering approaches have come out of Dave Gustafson's and others' work in Wisconsin, so I think it's really quite important. You know, as healthcare systems are trying to grapple with needing to really shift to a focus on prevention, I have to just say, in the interest of full disclosure, my answer to this is going to be very affected by my last 3 years spent at Kaiser Permanente, where I really had the opportunity to see a health system on the inside that really believed in prevention. And their focus was around, let's keep people well, let's make sure all the prevention-focused evidence is our first order of business with our what they're called their members, our patients, and then after that, then we take care of all the chronic diseases and other things. So in my thinking, that is exactly the way we should be thinking in healthcare. You know, prevent disease first, and then if we can't, then we focus on treating it. And a huge part of what they did there was to look at every aspect of that system as contributing to those efforts to increase prevention uptake. So they built it into every aspect of their care. When you call to talk to your the nurse practitioner in your providers group because you twisted your ankle and you think you might have broken it, they take care of that need, but then they say, oh, by the way, we noticed that you're behind on your screening. You haven't had your mammogram this year. Would you like us to make that appointment for you right now while you're waiting for the nurse to come on the line to talk with you? It's how you bring all of the aspects of the system into achieving not these siloed targets, but, you know, the entire whole person care. And I think we have so much to learn in implementation science from that approach, and could really turn the dime on trying to get prevention in particular implemented more broadly by taking that approach.
Thanks, and thanks for taking on that first crack at a challenging question. Larry, your thoughts about what can we learn from design thinking, system science, and implementation science together?
Well, I think that what Karen has outlined from her experience at Kaiser is a beautiful example of how we're going to have to take this in stepwise movements, because we can't encompass everything that public health has to encompass at the community level without first developing systems at the institutional levels, the institutions that make up communities, and build outward from there. I just don't see an easy pathway, especially since we don't have good surveillance systems for communities, a problem I addressed earlier. I think that systems analysis and system designs are really the ultimate key, but they are so overwhelming just in their pictorial presentation for most people to try to digest that we've got to find a way to simplify the communication of these systems approaches. As for design engineers, I'm now beyond the age of comprehending what's happening in that realm, and what strikes me as particularly problematic is that we're not going to be able to do the kind of NIH research that requires an application, a grant application, early in the presentation of a new system. And before you can get that grant application through the peer review process and funding, that engineering design application, that systems application, has been replaced by something else. So I think we've got to come up with a more rapid turnover of funding if we want to evaluate these new developments in engineering, computers, handheld devices, and software that accompanies them.
Yeah, and I think that was one of, for those who were on hand for our last Dissemination Implementation Science Conference in D.C., the opening talk from Roy Rosen, I think, was reflecting on this challenge of rapid design thinking, and are there ways in which we can apply as good science to what is a rapid moving terrain, and to what degree can we test the potential impact of things as early as possible, and what do we actually need as far as a concept goes to really try and gather more, I think is something that each of you had reflected on earlier, more of this design thinking, designing for dissemination and implementation. So great points, but always challenging when you've got a system that isn't necessarily the fastest moving one. We have another question that popped up that asks for your advice in terms of assessing and mitigating the effects of measuring implementation relevant factors on the success of implementation and external validity. Let me ask that again. What advice do you have for assessing and mitigating the effects of measuring implementation relevant factors on the success of implementation and external validity? Any thoughts there?
Karen?
Thanks, Larry. I wish that I could ask the person back. Maybe I'll try this to see if we can get some clarification. Is the question really about the fact that these seem like it feels burdensome to measure all of these factors? I think if that's the issue, and I think when you look at some of these conceptual frameworks, they are really overwhelming. There are so many aspects to think about. I think a lot of what I've seen, I served on the D&I study section until about 1.5 years or 2 years ago, and I think at the time what we were seeing was people not, cherry picking, but saying, look, here's the reason why we think this aspect of this model is the most important, and explaining why at different levels the whole thing might not be relevant, but there might be some specific parts that they felt were most important, and that seemed to fly there. So I think if that's the issue, it's just overwhelming to do all of these assessments. I think you do have to think carefully about what's most relevant to your topic, but not personally. I think staying at a single level is probably not the way to go.
Yeah, no, thanks, Karen. Oh, yeah, Larry, did you want to jump in?
Well, I guess what I'm struggling with is whether to try to answer this from the standpoint of the individual who's grappling with the complexities with limited control over the environment, or think about it at the institutional or community level where you can take systems and try to disseminate them downward into the community to different institutions so that they can collaborate more effectively with the electronic connections. I guess the most promising, and I hope Karen will correct me on this, the most promising thing that I see as a patient and as a university participant in development of systems is the electronic patient record. It seems to me that that has opened all kinds of new avenues for physicians, patients, and others to participate in understanding the complexities for the individual patient within the context of the institution and the community. So I don't know that this answers the query specifically, but it seems to me to be a pathway we might want to explore more systematically.
Yeah,
let me actually jump off of that, if I can, on the electronic health record, because I think that you're right. I think that's a really important pathway. I guess I would just say that there's a little bit for me of the gut response to say, garbage in, garbage out, and that is not that what's in the electronic health record is garbage, but rather so much that's not in the electronic health record is important. And so I think this movement towards trying to get more patient-reported outcomes, more, frankly, psychological and other kinds of more social kinds of measures into those electronic records is really, really important, certainly around social determinants and social needs. A lot of health systems are really trying to figure out, back to our earlier questions on disparities, how do they as a health system take into account and address the fact that, 90–95% of what's impacting and influencing their patients' health is happening outside the health system. Yet the health system, because of social determinants, yet the health system is trying to address these things and is, increasingly being held accountable. So you're seeing many more partnerships with referral agencies. In Kaiser in Colorado, they had a phenomenal partnership with Hunger Free Colorado, which is a really statewide system to try and address food insecurity, and they've done some really fantastic work there. But one of the challenges is how do you evaluate these going back and looking at the electronic health records when they don't necessarily have the level of detail and nuance that you would need to really understand the impact. So I think that the more systems move to appreciating the role of patient-reported outcomes, the more valuable the electronic health record will become as a tool for implementation science.
Yeah, and I think appreciation certainly from folks about acknowledging the need to include a whole range of aspects of healthcare beyond what's in the electronic health record. And just as further clarity for that question, I think there's always a concern, I would endorse this as well, that we may be forced to try and add more and more measures of different factors, and at some point there's that tension between how do we really identify what are going to be the most likely to influence implementation versus a huge number of different factors that we might have from our conceptual models across different levels of context. So just recognizing that this is a challenge. With only a few minutes left, and I see that there are a couple of questions that we'll try and get to, I did want to give you each a chance because folks on this webinar are at various different stages of their career. Was wondering what advice you have for folks who are earlier in their career and are thinking about a career in implementation science. What would you encourage them to do? What advice would you have? Maybe Larry and then Karen?
Yeah, my first advice would be get some early experience in community agencies and service delivery settings to complement your academic preparation for an academic career. I assume most people are here because they're doing research and therefore likely to be in academic settings or headed there. And I do feel that with the explosion of new schools of public health and programs in public health, that universities have had to scramble for faculty and have had to hire a lot of newly minted PhDs without any experience to teach about public health. And unless we build up a reservoir of training opportunities, or at least exposure opportunities for those people in public health agencies and community medical agencies and so forth, they're going to be teaching too exclusively from theory. So the second thing I would urge young people to pursue, and I have a recent article in Pedagogy and Health Promotion on this, is turnstile careers such as Karen and I have had with rotations periodically out of their academic professorships into practice agencies and policy agencies to understand what service and policy involves on a day-to-day basis. And I say it has to be done periodically, not just as a career starter, but conditions change, and over a period of a decade following a significant experience in the field, your teaching on that subject gets stale and irrelevant to changing conditions. And finally, I would say build working relationships with community partners and agencies through practice-based participatory research and invitations to them to conduct seminars and lectures to your students. Just more interaction between the academics and the field is the summary of those suggestions.
Great. Karen, quick thoughts, advice for early career investigators.
Yeah, one of the best things I ever did in my career was born by the fact that early on I didn't have much money, and so I embedded myself in a lot of our community-based work that we were doing. So we had a lot of partnerships with low-income subsidized housing communities, and part of that work, I was actually in the field doing data collection. It was very much of a CBPR approach, and we were using our team to help do some of the things that the housing communities wanted to do. We were working at their food banks and their food pantries and a variety of different things, and it made such a difference in my ability to understand what it meant to bring my interventions to that setting. And so I think it really builds on what Larry's saying about those partnerships. Really integrate yourself, embed yourself in the settings that you're trying to understand, because it will just open your eyes to things that you've never, ever thought of, and I think that's really critical. I guess I would also say, really include a range of outcomes, really thinking about this multiple level, multiple targets, multiple time trajectories, and try to incorporate that into the work that you do. I think it's quite important for improving the field as we go forward.
Okay, wonderful. There's one more question, and Larry, maybe if I can ask you to take a quick crack at it, and then of course we'll say thank you and close. A question about in a community, who would be the key stakeholders in implementing changes? It asks academicians versus public health versus community partners, and any quick advice on how we bring them together.
Well, I would not want to suggest there's any single answer to that because of the diversity, the heterogeneity, the cultural diversity of communities that you might be working with. So I think it has to be a part of an assessment of the community as you approach it to collaborate on any research. So there is not, I don't think there is a single answer as to who should be the collaborators. I think you have to approach that question incrementally with your relationship to the community.
Right. Thank you very much. So let me at this point just say thank you to our esteemed colleagues. Thanks, Karen and Larry, for sharing your wisdom. You can gaze upon this lovely fire from some past decade. And I'll turn it over to Sarah for closing.
And so with that, just very quickly, your feedback is hugely important to us, and we encourage you to complete our online evaluation, a link to which will pop up in the screen as soon as we wrap up here today. An archive of today's session is available, and that should go up in about 1 week on our website. If you have not checked out the chat on the right-hand side of your screen, several of the resources mentioned are linked to, and you can go ahead and grab those publications if they are of interest to you. We hope to see you at our next session held in March. Registration details will be shared in the coming weeks. Thank you again for joining us. Thank you to all of our presenters, David, Karen, and Larry, and you may disconnect at this time.
Thank you.